Good morning, everybody, and thanks to the organizers for inviting me to give this talk at this prestigious meeting. These are my disclosures. Let's start with a bit of background. We all know that the Sun Working Group gave us recommendation to grade intraocular inflammation in an agreed on grading cells, flare in the anterior chamber, and vitreous A's. And they gave also these sort of scales to refer to on the. Good morning, everybody, and thanks to the organizers for inviting me to give this talk at this prestigious meeting. These are my disclosures. Let's start with a bit of background. We all know that Sun Working Group gave us recommendation to grade intraocular inflammation in an objective way, and they agreed on grading cells, flare in the anterior chamber, and vitreous A's. And they gave also these sort of scales to refer to when we have to grade when we have to clinically grade them objectively. So we have cells in the anterior chamber, flare, and this is the scale that we are meant to use for the back of the eye. Now, all these scales remain the current paradigm for uveitis assessment, both in clinical trials and routine clinical practice till nowadays. But they suffer from some limitations. So they are subjective, they are non-continuous, and there has been shown that there is low agreement between two graders rating the same patient on the same day. So there is a bit of difficulty even if they are meant to objectivize the inflammation. And this basically tells us that we need better outcome measures both in routine clinical practice and clinical trials to assess intraocular inflammation in patients with uveitis. For this reason, groups of experts have tried to tackle this problem over the years with the aim to find objective measurements better than those we have already now. So we are in front of two possibilities. We have new biomarkers to look at, or we have better ways to measure old biomarkers. Now, the good point of looking at these last ones, so better measures of old biomarkers, is that we already know that these biomarkers work. We just need to be more precise in measuring them. And then we have new biomarkers. So we'll start with the old ones and then we'll move to the new ones. So as I said, better ways to grade something we already know is reliable in giving us an idea of what's going on in the eye. And the OCT in this plays a revolution. So we are now able to assess the number of cells in the anterior chamber with the anterior segment OCT, and this has been proven since 10 years now. This is the first paper on ophthalmology showing these, and then this is another one more recent where we were able to assess both anterior chamber cells and flare using an anterior segment OCT. This can be also applied to the vitreous. So back in 2014, the group from Moorfields proposed to look at the reflectivity of the vitreous, so the haziness of the OCT scans, to objectively correlate this with the haziness of the vitreous, so the vitreous inflammation. And this somehow works, but is also highly affected by media clearness, so this never really was implemented into clinical practice. More recently, we focused on cells rather than haze, and we found these cells in the vitreous to correlate way better with the clinical grading and to be much less affected by media opacity. So you see how the number of cells gradually increases with the different in IA clinical grading, and while the vitreous reflectivity doesn't really fit so nicely with the clinical grade. And this is just a scale to show how cells can vary in different grades of vitreous inflammation. The same can be applied also for anterior vitreous. using anterior segment OCT and just pushing the head of the device a bit forward, closer to the patient. Now, all these are, the ones that I just listed you are better ways to assess old biomarkers, so cells. And this can work regardless the kind of uveitis. But here we are focusing more on non-infectious posterior uveitis. So we have to look at specific features of these diseases. And for these, we need new biomarkers. Now, the pro of new biomarker is that it's an innovative way to look at the problem. It allows us to measure new things that are potentially better than those generic old biomarkers we looked at so far. But on the other hand, they need to be validated and they're not necessarily accepted by regulatory agencies. So we have to work a lot to implement these into the clinical practice. So one, and probably the most widely accepted both in clinical routine and clinical trials, is macular edema. Now we know that OCT to assess macular edema is probably the best way, and this has been already proven by several trials, several studies, and not all the non-infectious posterior uveitis have macular edema, but for example, birdshot chorioretinopathy can have it, and definitely this is a good way to objectively measure inflammation in this disease. Another way to assess inflammation in posterior uveitis is to look at choroidal thickness, and we know that the choroid gets thicker regardless the entity we are looking at, because it's kind of a non-specific biomarker for inflammation in the back of the eye. And the number of papers looking at this is been increasing in the last few years. So this is something we should always look at when we look at posterior uveitis, and non-infectious posterior uveitis are not an exception in this case. There are also more complex ways to look at the choroid and its activity. One of these is the choroidal vascularity index, which is the ratio between the lumen and the stroma of the choroid. And you can see that increase in CVI is basically can mean larger vessels, while decrease in CVI is usually attenuation of choriocapillaris or reduction in the size of choroidal vessels. And obviously this can be used to assess the inflammation in the choroid and to monitor patients with uveitis. Another feature that is probably not unique of posterior non-infectious posterior uveitis, but can be present, especially, for example, once again in birdshot, is the leakage from vessels, from retinal vessels. And there are ways now described to objectively measure this leakage. As you see here, we can measure both hypoperfusion in the fluorescein, so hypoperfused areas and leaking areas. And here are some examples of automatic algorithms allowing to assess this and to monitor this over time. As you see, for example, in the first line here, we have a lot of leakage, and then as the leakage decreases, the algorithm is able to catch this difference and to measure it objectively. Now, if we think about one of the most important infectious posterior uveitis, we know that APE shows these creamy lesions, and we know that this basically is related to the fact that we have hypoperfusion of the choriocapillaris. And this is nicely showed by ICG, which is however not always available, but is also very nicely showed by OCTA, as far as we place the slab of the OCTA at the level of the choriocapillaris. So we have these hypo-reflective areas which basically demonstrate the hypoperfusion of choriocapillaris, which is responsible for the damage in this disease. And we also know that we can track these changes over time. So for example, in this patient who received steroids, we can see that the hypoperfusion decreased from baseline to the last follow-up, and we can see that OCTA is able to demonstrate the change without need to repeat ICG. And obviously we can track these changes over time, and we can measure these areas of hypoperfusion and see how they change, increase, decrease, disappear, and this can be used as a guide to the treatment in these diseases. Obviously, measuring choriocapillaries is a bit of a challenge because the segmentation lines the automatic segmentation can fail due to the damage of the standard anatomy and the clumping of pigment on top of them. So always be careful and look carefully at these lines where they are placed, and if there is any misalignment, just adjust it manually before using these images as a reliable tool to measure hypoperfusion. We also know that this hypoperfusion is often accompanied by alterations at the level of the outer retina, which is actually what gives us the disturbances in visual acuity. And some researchers have looked at these alterations of the outer retinal layers on unfast OCT. So this is another nice way to look at the alterations in the outer retina and in non-infectious posterior uveitis. So this is one paper, and this is another more recent paper looking at this hyperreflectivity in the outer retina and measuring it, and this very well correlates even better than choroidal hypoperfusion with visual function. So to conclude, we have objective ways to assess the intraocular inflammation, and this is mandatory for proper management of patients with uveitis in general. And regarding non-infectious posterior uveitis in particular, we have new imaging techniques that can be applied to better measure the alterations in these diseases, even better than all the inflammatory biomarkers, but we need to work hard to standardize and validate these new techniques. And with this, I thank you for your attention.